The second phase of pharmacokinetics is called distribution. Distribution is the movement or transport of the chemical or drug through the body. The bloodstream or the peripheral vascular system is the main vehicle by which drug chemicals are distributed throughout the body. Obviously, the status or health of the circulatory system and the veins and the arteries will play a role in the distribution, both from the rate of distribution as well as the effectiveness of distribution. So, for example, somebody who has a long history of cigarette smoking and who has peripheral vascular disease in the lower extremities would have a very slow rate of distribution of drug chemicals to the peripheral extremities, for example. Therefore, if somebody had an infection in their toenail, the movement of drug to that toenail through the bloodstream would be complicated by decreased blood flow. In that case, we would look at the route of administration and determine that the enteral or parenteral route would be complicated due to the decrease in distribution, and the best route of administration would be topical and put the antibiotic, for example, right on top of the area where the infection needed to be treated. Another factor that plays a role in some concepts about distribution is the knowledge that there are some body tissues that receive a large amount of blood flow and other body parts and organs that receive a lesser amount of blood flow. So when we think about treating the lungs, for example, we know that the lungs receive a good distribution of blood. Therefore, a pneumonia in the lungs would be well treated with drugs that were in distribution in the bloodstream. In contrast, the bone receives very little distribution of blood via circulation, so it's very challenging to treat bone infections in general due to this thought. Another factor that plays a role in distribution is the idea of whether the chemical is lipid soluble or water soluble in nature. Lipid-soluble drugs are much more completely distributed because of the chemical nature and availability for easy diffusion through plasma membranes. Some tissues can store drug chemicals after absorption, and these include the eyes, the bone marrow, and the teeth. This becomes a consideration for certain drugs, namely one being tetracycline. Tetracycline is a well-known and commonly used antibiotic. It is also one of those drugs that is stored in bone marrow and teeth. So it gets absorbed and distributed via the bloodstream, and then some of those drug chemicals of tetracycline are harbored in bones and teeth. What this means is that at any point in time, the stored molecules of tetracycline can come out of the bones or out of the teeth and get back into distribution to be active again in the body. This is helpful for certain treatments with tetracycline, for example, acne. Acne is a bacterial problem and often chronic in teenagers and young adults, which sometimes require the treatment of tetracycline. Tetracycline is useful because of this distribution and storage in bone marrow and teeth, and we can safely use periodic doses, for example, once a month dosing of tetracycline, and know that the patient is getting coverage over that month because of this storage issue. An additional concept that we need to think about in the realm of distribution is something that we call the affinity of a drug chemical or molecule to form a bond with a protein molecule. Specifically in the body, we're thinking about the protein albumin. There are some drugs, and you will read about this when you're studying them, that are said to have a high affinity to be protein bound. What that means is when the drug is administered into the system, it looks for a albumin protein to bind to. When the drug chemical binds to a protein albumin molecule, the drug is found to be inactive. It is not in the active state when it is in the bound state with the protein. At any point in time, the drug molecule can come out of the binding relationship with the protein, which again makes it an active drug in the system and can cause its effect in the body. This is important to know because when the chemical is bound to a protein or when the chemical is unbound from the protein is arbitrary. There is no predictive ability that we have as healthcare providers. So the dosing of the drug takes into consideration the potential for the molecules to look for proteins to bind to. So when patients are subtherapeutic in their response to a drug, and it is a highly protein-bound drug, we think about whether there is too much in the binding phase, and sometimes we need to increase the dose. Additionally, another important concept related to this is in a situation where patients are malnourished. People who are malnourished have low numbers of protein albumins in their body. So if a drug that is deemed to be highly bound to proteins is administered and there's not enough albumin proteins in the body, that means there's a lot of free-floating active drug chemicals in the bloodstream, and often this can cause the patient to be thrown into toxic levels of the drug. So when people are malnourished and their albumins are low in their bloodstream, incidentally, this is something that can be followed via a blood draw. You could draw a sample of patient's blood and measure the amount of albumins. So again, we have a scenario that the patient has low albumins. They are getting a drug that needs this protein albumin to bind to. We often see that the doctors lower the dose so as to not cause a toxic syndrome in the patient. The drug protein complex that we just thought about is unable to cross the plasma capillary membranes. So therefore, the drug is unable to be distributed to tissues. So again, drugs that are highly protein bound, when they are in the bound state, are not considered active and will not have a therapeutic effect in the body. Okay, it's the unbound free drug molecules that distribute and reach the target cells and cause a response of therapeutic effect.